And we're now going to start talking about tumors that affect the genitourinary tract. We're now on vignette number 13. A 62-year-old man known to have normal renal function reports an episode of gross, painless hematuria. Further questioning determines that the patient has total hematuria rather than initial or terminal hematuria. Well, that description means the blood is coming anywhere from the kidneys to the bladder rather than the prostate to the urethra. Either an infection or a tumor can produce hematuria, and in fact, most cases of hematuria are due to benign disease rather than cancer. But obviously, our obligation whenever we see a patient with hematuria that is unrelated to trauma is to rule out cancer. This patient could have a cancer of the kidney, a cancer in the ureter, or a cancer in the bladder. We can identify a cancer of the kidney, a cancer of the ureter, with either an IVP, the older technology, which is incidentally why this vignette points out that the patient has normal renal function, because we cannot do an IVP if renal function is compromised. Or it could be diagnosed just as well, perhaps even better, with a CT scan. But you know, neither the IVP nor the CT scan are very good at detecting early bladder cancers. For that, we need cystoscopy. So if you find an answer on this question that says do IVP and cystoscopy, it would be good. And if you find an answer that says do CT scan and cystoscopy, it would be good. But you need the two. Let me move to vignette number 14. A 70-year-old man is referred for evaluation because of a triad of hematuria, flank pain, and a flank mass. He also has hypercalcemia, erythrocytosis, and elevated liver enzymes. This is the quote, classic end quote, full-blown picture of renal cell carcinoma. Very rarely seen nowadays. Very rarely seen because anybody in this country who has an episode of hematuria gets checked. And so it'd be unusual for renal cell carcinoma in this country to grow to the point where there is a palpable mass and there is pain in addition to the hematuria and even the paraneoplastic manifestations of the tumor. And yet, as described, you know right away, this is a renal cell carcinoma. And probably your best answer on this particular vignette would be, let's do a CT scan. Let's talk a little bit more about renal cell carcinoma. There are a number of things that are peculiar about it. Imaging techniques are so good in urology that we frequently see surgery done for cancer based on the images alone, without the need for a biopsy ahead of time. And that's frequently the case for renal cell carcinoma. The picture on the CT, or for that matter on an IVP or a sonogram, tends to be so classical that the urologist already knows that is a renal cell carcinoma. Surgery is about the only effective therapy for it. We're always constantly looking for ways to enhance our therapeutic efforts with chemotherapy, with other modalities, but the main modality for renal cell carcinoma remains surgery. It doesn't necessarily have to take out the entire kidney, by the way. If it is a very small renal cell carcinoma, we can do a partial nephrectomy. If it's a bigger tumor, a total nephrectomy, perhaps even with Gerota's fascia being removed. But renal cell carcinoma has another feature that's sort of unique. It has a tendency to grow into the lumen of the renal vein. And left alone, it could grow into the lumen of the inferior vena cava. Well, when doing a nephrectomy at some point in the technical steps, a clamp will be placed across the renal vein to do the resection. If we are unaware of the fact that there is a tongue of tumor that has grown into the lumen of the renal vein and clamp it and break it, that tail of the tumor will go to the lung and do a pulmonary embolus. And so one of the ways to ascertain whether there is indeed that situation or not is with a CT scan. And it's one of the details that makes the CT scan such a good diagnostic test when we're dealing with renal cell carcinoma. Let us now move from cancers of the kidney to cancer of the bladder. We are now on vignette number 15. A 55-year-old chronic smoker reports 3 instances in the past 2 weeks when he has had painless, gross, total hematuria. In the past 2 months, he's been treated twice for irritative voiding symptoms, but has not been febrile, and urinary cultures have been negative. You know, every person in the United States, not only every physician, every person knows about the relationship between smoking and cancer of the lung. What few people realize is that the relationship between smoking and cancer of the bladder is even more impressive. So a long-time smoker with this kind of symptomatology, you think immediately of bladder cancer, for which the only effective diagnostic modality is cystoscopy, remember? And yet you don't want to pick an answer that just says, do a cystoscopy. Because the same transitional epithelium that lines the inside of the bladder lines the inside of the ureter and the collecting system. These tumors are often multicentric. If you zero in on the bladder, see a bladder tumor, and treat that bladder tumor, you could miss the other tumor that is in the ureter or in the collecting system. And so traditionally the sequence has been do an IVP followed by a cystoscopy. And nowadays that same sequence might be do a CT scan followed by a cystoscopy. But remember, we have to check the upper part of that urinary tract as well. We're now going to cut away from my face and go look at a few screens with words to remind ourselves of some of these issues. So now we're confronted with a question on the exam that gives us hematuria unrelated to trauma. If it is total hematuria, by which we mean throughout the voiding time, the bloody urine comes out. It is not blood at the end of urination or blood at the beginning of urination, but throughout. The source is in the kidney, the ureter, or the bladder. If it is initial or terminal hematuria, the source is in either the bladder, the prostate, or the urethra. If we have total hematuria unrelated to trauma, the workup includes an IVP, a sonogram, or a CT scan to reveal a renal source. Remember, either of these would be a good test to show us a tumor in the kidney. We probably favor the CT scan because it will also give you additional information like, is a tumor in the kidney growing into the renal vein? And so we begin the workup with one of those. But remember, neither of those is terribly good for the bladder. Only a cystoscopy will reveal early bladder tumors. So that has to follow. A cystoscopy must follow. Let me say a few more things about bladder cancer. Bladder cancer can be treated with something less than a total cystectomy if we find it early. If we find it advanced, obviously we have to get rid of the entire urinary bladder and do an ileal conduit. But if we do a partial resection, the follow-up on that patient needs to be extremely compulsive and forever, because recurrence of bladder cancer or the growth perhaps of new bladder cancers, if you like, is extremely common. So the follow-up is forever. Cystoscopies at frequent intervals. And one of the measures that has been found to help minimize that rate of recurrence is the local injection of BCG into the bladder. And this is a non-specific stimulant of immunological reaction. It began life as a vaccine for tuberculosis. So that BCG has a role in the management of bladder cancer. Now, let's move on to other types of cancer in the genitourinary tract. So now we're going to read vignettes number 16 and 17. A 59-year-old black man has a rock-hard, discrete 1.5 cm nodule felt in his prostate during a routine physical examination. And vignette number 17. A 59-year-old black man is told by his primary care physician that his prostatic specific antigen, PSA, has gone up significantly since his last visit. He has no palpable abnormalities in his prostate by rectal exam. These are the two ways that we can identify early prostatic cancer that we can treat. It's either a rock-hard nodule that the finger feels on the rectal exam, or a PSA elevation. And these two tests are complementary of each other. One of the two may miss a tumor that the other one may pick up, so we typically do both. Once we have been alerted by either the rectal exam or the PSA that there may be a cancer in the prostate, we do biopsies of that area. We do core biopsies. Well, if we found the suspicious area with the finger, that same finger can guide the transrectal biopsy of the nodule in question. But if it was a PSA that alerted us and there was nothing the finger could feel, then we do a transrectal sonogram. And that ultrasound done through the rectum of the prostate will identify the nodule that should then be biopsied. Once the diagnosis has been established, I am venturing a guess that the USMLE will not ask you how to treat a particular patient, because there is a bewildering variety of things that can be done for prostate cancer. We can treat it with surgery, and the surgery could be transurethral or via the abdomen and the bladder. We could treat it with radiation. The radiation could be external beam or seeds that are put into the tumor. There is a role in specific cases for node dissection. There is a role for hormonal therapy. It's such a complicated issue that I think it takes the expertise of a urologist to advise a particular patient on what to do for that particular situation, and doesn't lend itself to an easy kind of question on the USMLE where a simple single therapy would have to be recalled. Now, having said that, though, I want to alert you to one aspect of the treatment of prostate cancer that is so peculiar to it that you should be aware of it, and you might encounter a question dealing with it. This is now vignette 18 we're on. A 62-year-old man had a radical prostatectomy for cancer of the prostate 3 years ago. He now presents with widespread bony pain. Bone scans show metastases throughout the entire skeleton, including several that are very large and very impressive. Well, if it wasn't already done as part of the initial treatment, we can gain pretty dramatic palliation by doing bilateral orchiectomy. It will not be long-lasting. It will not cure the patient. It will be only a couple of years, perhaps, but there will be a couple of years of significant improvement. Now, the orchiectomy, some patients are reluctant to have it for their own personal reasons, so there are some alternatives, much more expensive, much less reliable. But we can use luteinizing hormone, releasing hormone agonist, or anti-androgens like flutamide. Now we move to vignette number 19. A 78-year-old man comes in for a routine medical checkup. He is asymptomatic. When a physician had seen him 5 years earlier, a PSA had been ordered. But he notices as he leaves the office this time that the study has not been requested. He asks if he should get it. Well, the answer is no, he should not. Let me explain why. Any male who has not been previously castrated, that is, any male who still makes androgens, is likely at some point in his life to develop prostatic cancer. It's very common. However, if that prostatic cancer begins very late in life, it would take so many years before that cancer is a source of problems that typically the patient would be dead before that happened. And so one reaches a point in life when the discovery of an early prostatic cancer doesn't really make much sense. Because if we were to discover one, we probably would do nothing about it. We'd just choose what's called expectant therapy, just watch it. And that age is roughly around 75. And so the answer in this vignette would be, this gentleman really should not be getting the PSA anymore. We're not going to do anything with the PSA. Now we move from the prostate to the testicle. This is now vignette 20. A 25-year-old man presents with a painless, hard testicular mass. It is clear in the physical examination that the mass arises from the testicle rather than the epididymis. To be sure, a sonogram was done. The mass indeed was testicular. Now, if you don't know what the correct answer is, you're going to be horrified. Because the correct answer is we do a radical orchiectomy by the inguinal route. And after that mutilating, irreversible step, we ask the pathologist, hey, was there a cancer on that testicle we sent you? You say, how can you do that? You need a biopsy ahead of time. Well, actually, we don't. Because as it turns out, virtually there are no benign tumors of the testicle. So when we see a tumor of the testicle in a young man, it's bound to be cancer every single time. We're going to take a sample of blood for the hormones that testicular cancer may make, but that's going to be primarily to help with the follow-up, not so much to decide right now what do we do next. And incidentally, any answer you might find for this question that does anything via the scrotum is wrong. That orchiectomy should not be done via the scrotum. You do not do biopsies via the scrotum. You don't even do the FNA. Remember when we talked about the FNA? And we said one of the very few contraindications to an FNA, don't do an FNA of a testicular mass. Well, here you have it. Okay. After the orchiectomy has been done, depending on the extent of the disease, there may be a role for no dissection, there may be a role for chemotherapy and so on. But the management as described for this vignette would begin with that orchiectomy by the inguinal route. Well, let's pursue the theme though a little further. A 25-year-old man is found on a pre-employment chest x-ray to have what appears to be a pulmonary metastasis from an unknown primary tumor. Subsequent physical examination discloses a hard testicular mass, and the patient indicates that for the past 6 months he's been losing weight for no obvious reason. Well, obviously this is a testicular cancer, but it already has metastasis. And so you might wonder, boy, what can we do with this? This is already far advanced. Well, actually, we can probably still cure this man. You see, testicular cancer is extremely radiosensitive and chemosensitive. We begin the management here with the very same radical orchiectomy by the inguinal route that we talked about before. And then we put this man on platinum-based chemotherapy. And that platinum-based chemotherapy has an excellent chance of getting rid of the remaining disease, and this man could in fact be cured. And this is the end of our review of tumors of the upper part of the genitourinary tract.